Thanks, everyone, for coming this morning. We're going to start the primary care session this morning with a review of the blood pressure thresholds and targets, and particularly talk about some changes that have happened since the release of the SPRINT trial. So these are my disclosures. I have Tri-Council and sort of nonprofit funding, but no pharma, no funds from pharma. And the objectives of this session are to review the Hypertension Canada recommended SVP and DPP thresholds and targets, and discuss strategies on engaging patients in blood pressure lowering. So I do want to give a lot of credit to our dedicated volunteers that work on the Guidelines Committee. This is a picture that was just taken yesterday, actually, as we took a break from our deliberations at the Consensus Conference. And just to give you just a little bit of an overview of our process, we have over 60 volunteers, and these are largely researchers and clinicians from across the country from a variety of disciplines that work in a variety of expert subgroups. Each year, they review all of the evidence that's emerged in their field, and they bring forth recommendations that they feel are relevant to our patients. We have an independent review process called the Central Review Committee. These are an expert of independent methodologists that vet not only the recommendation, but all of the evidence underpinning it and give us a sense of what the grading of the recommendation should be. And then these recommendations are then presented at our Consensus Conference, and recommendations that are deemed clinically important and based on strong evidence then are approved and added to our guidelines. And so this group of people did that work yesterday, and it's a great pleasure to work within this community. So getting right down to our thresholds, Hypertension Canada has 4 treatment thresholds for patients with hypertension. And we recently added the new high-risk or SPRINT population threshold, which states that we should be considering treatment when the systolic blood pressure rises to 130 or above. For patients with diabetes, we recommend that treatment be considered when the systolic blood pressure gets to or above 130, or the diastolic gets to or above 80. For those at moderate risk for cardiovascular disease, and how we define this in our guidelines is if there's evidence of target organ damage from hypertension, so primarily left ventricular hypertrophy, then we suggest that you should be considering initiating treatment when that blood pressure gets to or above 140 on the systolic side or to above 90 on the diastolic side. And for everybody else who it would be considered low risk, those are, while I say everybody else, this population is actually fairly narrow. Low risk patients are patients that have elevated blood pressures but don't have any evidence of target organ damage or don't have a high burden of cardiovascular risk factors. If they do have a large number of cardiovascular comorbidities, if they have diabetes, if they have hyperlipidemia, if they have comorbid obesity, then they would be in that moderate category. But in the absence of those risk factors and in the absence of target organ damage, you don't need to consider initiating treatment until their blood pressure reaches a systolic threshold of 160 or a diastolic threshold of 100. So once you've initiated treatment, where do you need to go? And Hypertension Canada has 3 distinct targets. So for that high-risk population, which I'll define in just a moment, and again, that's largely informed by SPRINT, the high-risk target is a systolic of less than 120. If you have diabetes, your systolic target is less than 130 and your diastolic target is less than 80. And for everybody else, whether you're at moderate risk or low risk for cardiovascular disease, our target treated blood pressure is a systolic less than 140 and a diastolic less than 90. So let's just focus in on this high-risk population, and I want to give you some I want to just give you the background as to why we felt that this was an important threshold and an important target to introduce. And as we go through, which largely is the SPRINT trial, I want to not only give the evidence for the target, but also understand how this trial was quite pivotal in teaching us about various aspects of hypertension care. And so I'm hoping at the end of this presentation, while it is about thresholds and targets, kind of emphasize the importance of a comprehensive strategy in terms of lowering blood pressure in primary care. So again, this is a newish guideline. We introduced the sprint guideline in the 2016 guidelines. And what our guideline explicitly states is that for high-risk patients aged over 50, with a systolic BP of greater than or equal to 130, intensive management to target a systolic blood pressure of less than or equal to 120 millimeters mercury should be considered. Intensive management should be guided by automated office blood pressure measurements. And patient selection for intensive management is recommended, and caution should be taken in certain high-risk groups. So as we look at this recommendation, I think it's really important to emphasize that it's not just about the target or the threshold. It's about measuring blood pressure appropriately and accurately, and it's also about talking to your patient and identifying them appropriately for this target. So this recommendation, again, isn't just about thresholds and targets. It is about a more comprehensive approach to high-risk patients. So, and what do we mean by high risk? And so how we operationalize that in our guidelines is we really sort of took from the SPRINT trial, looked at the people they enrolled, and tried to make sure that we were applying this more intensive target and treatment strategy to those that were explicitly studied. So in SPRINT, these were patients that had clinical or subclinical cardiovascular disease, had chronic kidney disease, that was non-diabetic and non-proteinuric, or they had an estimated 10-year global cardiovascular risk of greater than or equal to 15%, and that was calculated using the D'Agostino Framingham tool, or they had an age of 75 years or greater. So patients with one or more of these clinical conditions were eligible for enrollment and were considered high risk and eligible for intensive targets. So I won't go into the granular details of the trial, but probably most people are familiar now with SPRINT. And basically, this was a trial of just over 9,000 patients that met those clinical criteria, that were randomized to either an intensive treatment arm, where they were a systolic target of 120 was employed, or a standard treatment arm, where the systolic target was less than 140. And the trial was actually stopped early, after a little over 3 years, when there was recognition that those in the intensively treated arm were doing much, much better. There was a 25% hazard reduction in major cardiovascular events, and there was a 27% reduction in all-cause mortality. So at that point in time, the Data Safety and Monitoring Board felt that it was unethical to continue because there was such a dramatic benefit associated with the intensively treated arm. And then when they looked by pre-specified clinical subgroups, the benefits seemed to be quite consistent across subgroups. So regardless of whether you had regardless of your gender, regardless of your age, and regardless of your ethnicity, there was a fairly consistent benefit seen. So this was quite a robust finding. Of course, when you're intensively treating patients, we have to worry about, are people encountering adverse events related to that treatment, and indeed, when you intensively treat people, you're going to come across a few side effects. Interestingly, when you look at all adverse events, the event rate was quite similar in both the intensively treated and standardly treated arms. So a little over a third, which is not negligible, of patients enrolled in this trial had some adverse event. What is notable, though, that those adverse events that brought people to hospital were more prevalent among those in the intensively treated arm. So people who were randomized to a systolic blood pressure of less than 120 were more likely to have hypotension that brought them to the emergency department, more likely to have syncope, and were also more likely to have acute renal injury. So it is important to know that not all high-risk patients are necessarily SPRINT candidates. We are very explicit in our guidelines regarding the fact that we have confidence around a subset of high-risk patients, but there's a number of high-risk patients that we really are a little less certain about. And in particular, and these are all studies, these are all patient subgroups that weren't explicitly studied in SPRINT, but maybe have been studied in other analogous trials. So we have limited evidence in patients with heart failure. We don't have any evidence in the institutionalized elderly. They were systematically excluded from SPRINT. We have inconsistent evidence on intensive blood pressure lowering, and that's lowering to a threshold below or a target below 130 in patients with diabetes. That's and this is a space that we're watching, and to find out whether we need to do any adjustment to our targets there. But as of now, We still think that 130 over 80 is the target we're advocating for. But again, there's inconclusive evidence regarding further blood pressure lowering in patients with diabetes. Stroke is an area that's under active investigation. There's a large trial that's set up to look at 3 different systolic targets, and this is being sponsored by China and the European Hypertension Society. So that trial's ongoing. So we'll get more information about blood pressure lowering in patients with prior stroke in the years to come. And we don't know about intensive blood pressure lowering in patients with more advanced kidney disease. And again, this is for such a prevalent population, a very difficult population to study. So I'm not sure if we're going to get much more data, but we don't know about intensive blood pressure lowering in that population. So these are very high-risk groups, but the data is a little less clear on the value of systolic BP lowering beyond the currently recommended targets. And there are a number of patients that we should just walk away from in terms of we definitely don't want to be going anywhere near 120. And these are patients that are unwilling or unable to adhere to their medications. So if you have a patient who does otherwise meet the SPRINT criteria, but you just know you can't reliably engage them, you should not feel obliged to go after that target, and we would discourage that. And if they've got some evidence of severe orthostasis at the time of evaluation, if their standing blood pressure is less than 110, again, these patients were excluded, and it's likely not entirely safe to pursue aggressive targets in those individuals. If you can't measure the blood pressure accurately, then clearly, probably don't want to be too intense, and we would encourage you to find alternative measurements strategies. And if they're someone with known secondary hypertension, then again, this isn't applicable to them. So just some quick reflections on SPRINT. In my mind, the value of intensive blood pressure lowering really lies in the intensive and high-quality care these patients received in the context of this study. People had clinical assessments every 1 to 3 months. The investigators used high-quality BP measurements after 5 minutes of rest. And so really did a very systematic approach to measurement that likely led to more accurate results. They used evidence-based, long-acting antihypertensive medications, and they prescribed in a way using single-pill combination therapies that were going to optimize adherence. So they really created winning conditions for the patient to do well. They used protocolized care to avoid therapeutic inertia, and they of course, had the benefit of study nurses, and we know that transdisciplinary care is very beneficial for the treatment of most chronic diseases. And the choice of patients that were high risk, but also highly engaged. So this really was a trial that really tried to engage the patient as much as possible. And so I think it's all of these ingredients that led to success in this trial. So while it is often, we often just think about the target, I think we have to remember the context with which this target was evaluated. So the key message is the target may be less important than attention to process. At least that's my opinion. Also, I just want to kind of emphasize, I won't go to this meta-analysis in great detail, but Etihad did a comprehensive systematic review to really, and it helped us understand what's a whole body of evidence that supports more intensive targets in high-risk patients. And what this systematic review showed in the end is that there was a strong linear relationship between the degree of SBP lowering identified in a number of randomized controlled trials looking at the benefit of blood pressure lowering in hypertensive patients. And they found that for every 10 millimeters of mercury that we reduced the systolic blood pressure, there was a 20% reduction in major cardiovascular events. So when we were deciding about whether we were going to integrate the findings of SPRINT into our guidelines, we had the benefit of this meta-analysis and another meta-analysis by an investigator named Z that provide quite compelling evidence that the lower the blood pressure is in high-risk patients, the better they're going to do. So when I've talked about the SPRINT targets before, often the common concerns that I hear is that pursuing SPRINT targets is very health system intensive, and monitoring for adverse events takes a lot of time, both on the provider side and the patient side. And there's a lot of concerns that older patients just simply won't tolerate these lower BPs. So I just want to address these concerns briefly. So indeed, pursuing intensive blood pressure lowering is going to be resource intensive. To do it well, as I mentioned, people need to see their doctor frequently. They need frequent follow-up to survey not only for treatment response, but for adverse events, and they need therapy. There was Adam Bress looked at NHANES data from the States, so National Nutrition and Health Survey data, to try to estimate how many Americans might be eligible for a SPRINT target, and found that 7.6 of the adult population in the States, or 24.5 million people, would be eligible for intensive targets, just to get a sense of, what were their healthcare needs going to be. And in Canada, we're looking at similar data and suspect that the number's also going to be rather large. But I think in the end of the day, we have to remember that blood pressure is really important. And when we look at global population health data, we have to remember that hypertension is right up there with tobacco in terms of leading causes of preventable death. So as much as it might be intensive, it's a really, really good use of resources in my mind. And so the adverse events, 37.5% of patients enrolled in SPRINT had some adverse event. And regardless of their intervention arms, so whether it was standard or intense, people had problems. And when we were reviewing this evidence for the guidelines, I thought that this quote from a colleague, George Dresser in London, was fantastic. And he said, probably this reflects that both hypertension and hypertension treatment are inherently risky. And so we probably want to err on the side of doing something and watching people closely as opposed to not doing anything or doing something less intensively. But it's noted that you have to watch these folks closely to try to get ahead of any potential complications of treatment. And again, when you do intensive blood pressure lowering, you have to have attentive care as well. As far as the treatment burden, it probably wasn't as great as you might think in terms of these high-risk patients, especially the patients with chronic renal disease. To get to a target of 120 on 2.8 medications is pretty efficient care. And again, this probably highlights the fact that they were very strategic in terms of the therapies that they were prescribed, again, hoping to promote adherence. For elderly and intensive SBP lowering, SPRINT examined outcomes by treatment and frailty status, and whether patients were fit, less fit, or frail. The outcomes were better for those intensively treated. Also, SPRINT showed that intensive treatment was not associated with an increased risk of falls or orthostasis among those who were treated, but also important to note that the adverse event rate was a little bit higher in the older patients as well. Again, evenly distributed across groups, but higher. So this is a patient population that should be treated, but also should be watched appropriately closely. So just a quick couple words on setting BP goals and targets. And I did want to emphasize that I think we use the terminology of thresholds and targets in our guidelines, but I don't, when I'm talking to my patients, I often try to frame things as goals that are often mutually agreed upon, as opposed to a target that's imposed, because I just don't want patients to feel like they're in my crosshairs. It's my son. And we also want to acknowledge it on the guidelines side that we deal with the evidence that lies on the left-hand side of the screen. We review evidence of well-defined patient populations with very, very discrete, neat interventions, and we realize that in reality, most people are on the right side of the screen, where you're never dealing with any one thing in isolation. One therapy that you prescribe might interact with another therapy that they're taking for another condition. So it's never that neat. Again, I think the challenge always at primary care is trying to translate our discrete groups into a population that has a lot of comorbidity and are inherently complex. And I think that, so just reflecting back on SPRINT, I think SPRINT provides compelling evidence that a structured approach to care and lowering BP improves outcomes. So just, I think, again, it just supports that when you have that structured, when you're really, really adherent to the principles of patient-centered care, we're going to do well by our patients, regardless of how low you get that blood pressure. And again, I think that SPRINT emphasized the importance of protocolized med adjustment, frequent patient contact and feedback, regular assessments for adherence, and the use of a multi-professional team. It also provides evidence that well-selected engaged patients are capable of being agents in BP lowering. And I think that we had a lot of discussion at our consensus conference yesterday about how when we do preliminary assessments of patients, this provides an incredible opportunity to engage patients. And so when we're selecting appropriate targets and doing developing shared strategies towards BP goals, global assessment of the patient, cardiovascular risk assessment, assessing health priorities, and patients' capacity and desire to be a partner in their BP lowering, I think is quite critical. And I just want to take a second just to emphasize again that when you sit down and do cardiovascular risk assessment, not only are you able to stratify the patient in terms of their cardiovascular risk, there's a lot of data that suggests that taking that time, going through risk factor by risk factor and communicating to the patient how all of these risk factors interdigitate and articulate to increase their risk is an incredibly powerful engagement opportunity. We know that patients that have that moment with their care provider, they get to their targets faster and they do better in the long run. And we reviewed more data this week that sort of makes us think that this point in patient contact is really, really critical. So, and while it will help you choose a target, it will also help you engage your patient. And I think at the end of the day, targets identified through informed dialogue that engages patients are going to be valid targets. So you know your patient best. The patient knows them obviously the best. And you know, whether you decide to land on a target of 120 or not, that dialogue has value. And you might be surprised at how effective you are in your BP lowering, just taking that approach and having that mindset. And knowing that, we certainly want you to achieve good blood pressures, but at the end of the day, we trust you to apply the evidence that we're providing through our guidelines. So in the end, Hypertension Canada provides evidence-based guidelines to inform best care, and the guidelines should be used as a tool in shared decision-making around BP management. But at the end of the day, sort of the key thing that we're trying to communicate with our guidelines is that high-risk patients should be treated at lower thresholds, and lower targets need to be achieved for maximal benefit. So with that, I'll pass it over, and I'll just leave that up for a second. At the Guidelines Committee, we do really want to make sure that we're providing you the guidance, the information that you require. So if you have any feedback on how we can do that better, please let me know. Or if you feel like you want to become involved in the guidelines process, also feel free to contact me. Thank you.